Um, well, I want to thank everyone for coming. It's good to virtually be here with everyone. I'm here in San Diego, and I know you guys are all over the country. It's actually a rainy day here in San Diego, so it's not a bad day to be inside. We have an amazing panel of physicians to talk to us today, where we're going to go over various different blood cancers and some of the latest advances. And this stuff, it's complicated even for physicians, but the team we have here today is going to really break it down. And the whole point of this is so you as patients can understand kind of where we are with the field for these certain cancers and have a better understanding of future therapeutics and what these things mean. So the whole point of this is to be extremely educational, and I really want this to be interactive. So please ask questions, type away, and our team will do the best to answer all of these things. So I look forward to a great talk by my awesome colleagues, and I hope everyone enjoys. So what we are going to talk about first is multiple myeloma and cellular therapies. And this, I'm a blood cancer doctor. I treat all different blood cancers, but myeloma, the field has exploded. The investigators have run amazing trials with numerous new therapeutics, and the new cellular therapies, CAR T cells, which are engineered immune cells, are able to work in patients who used to have limited treatment options. We're seeing amazing results. So without further ado, we'll get to our first talk by Dr. Rajiv, who is a hematology oncology fellow at the Eakin School of Medicine at Mount Sinai. She has an interest in lymphoid malignancies, myeloma, and cellular therapeutics. She's board certified, and she's going to really get to the basics of some of these cellular therapies. So please go away.
Hi, good morning, everyone. I'm going to go ahead and share my screen, which I think I need access if can one of the hosts please provide me access to share my screen real quick? There you go, I got it. Great. Can you all see my screen?
Yes.
Perfect, thank you. So good morning, everyone. I think, thank you so much, Dr. Goodman, for that introduction. My name is Sri Devi. I'm a third-year hematology and medical oncology fellow at the Icahn School of Medicine at Mount Sinai, with an interest in lymphoid malignancies, specifically myeloma and cellular therapies. And I'm very honored to be asked by Grace to be a part of this patient education session. So what I've tried to do with this is actually, take the whole concept of multiple myeloma and how we think about it, how do we approach the disease, and what are the cellular therapies that have been a little bit, changing the paradigm of how we treat, and explain it all in a patient-centric manner. So I've tried to break it down to as simplistic as possible. We're more than happy to answer any questions as they come. So without any further ado, we can get started. So multiple myeloma is actually a very relatively uncommon cancer. It's considered to be a form of a hematological malignancy, meaning it's a kind of a blood cancer, and are primarily treated by hematologists and medical oncologists. Multiple myeloma specifically is a cancer of plasma cells. Now, what exactly are plasma cells? There are white blood cells and red blood cells and platelets in all of our blood. There are kinds of white blood cells called B and T lymphocytes, which are very critical to our immune system. And the B lymphocytes are very important in facing infections and reacting to it. So when B lymphocytes actually respond to an infection, they mature and they learn to produce antibodies. And in this maturation process, they turn into what we call plasma cells. These plasma cells make specific antibodies, which are also called as immunoglobulins, against the infectious agent they encountered. Normal plasma cells are usually found mainly in the bone marrow and also sometimes in the peripheral blood, and they are very important parts of the immune system. And again, multiple myeloma is an abnormal state in which plasma cells multiply uncontrollably. According to the American Cancer Society statistics for 2023, in the United States, the lifetime risk of developing multiple myeloma is 1 out of 132 people, which is like less than 0.76%. The vast majority of cases are expected to occur in patients more than 65 years of age. And 50% of those patients diagnosed with multiple myeloma are expected to live beyond 5 years after diagnosis. An estimated 130,000 of patients in America, in United States, are currently living with multiple myeloma, with estimates pointing to as high as 30,000 new cases being diagnosed each year in the United States. So just taking a step back and going back into basics, like what exactly is a plasma cell and what exactly are all these antibodies we keep talking about? So I alluded to what a plasma cell was before. It's a B cell that has become mature and it produces antibody. The diagrammatic depiction of an antibody is what I've shown on the right side. You know, that Y-shaped symbol is like how we represent antibodies. It has what we call a light chain component and a heavy chain component. The light chains can be either a kappa or a lambda, like the Greek symbols, and the heavy chain can be immunoglobulin or IgG, E, D, M, and A. So these are the 5 kinds of heavy chains that comprise the immunoglobulin molecule. Plasma cells can produce sort of any type of antibody or just light chains by itself. And plasma cells are present in a normal bone marrow. However, in multiple myeloma, there is an overgrowth of plasma cells in the bone marrow, which can crowd out normal cells and can cause very low blood counts in those affected with myeloma. So because our body faces multiple different kinds of infections, you can imagine there are multiple different types of plasma cells that produce all kinds of antibodies. And that's the normal state in the body, meaning there are polyclonal, meaning multiple different types of plasma cells, producing polyclonal antibodies, meaning multiple different types of antibodies. Multiple myeloma, on the other hand, is when one particular kind of plasma cell multiplies uncontrollably, resulting in an overproduction of one single type of antibody, which is called a monoclonal antibody. And these monoclonal antibodies, again, will only have either kappa or lambda light chain. So in the myeloma bone marrow, sometimes these plasma cells and healthy B cells can undergo DNA damage, and these damaged cells transform into plasma cells, generating a lot of M proteins. So that's how how multiple myeloma comes into being. There are risk factors that are thought to be, genetic in nature, environmental in nature. However, a clear association is yet to be charted out. What are the common lab tests we often talk about in myeloma? When you come to see the doctor, if you have multiple myeloma, what are the lab tests we send, and what are the lab tests that we look at and discuss back with you when we have the results? We call them myeloma markers, and let's have a quick look at that. One of the first tests that we send is something called as electrophoresis. Electrophoresis can be sent in the blood as well as urine. It's nothing but placing that tissue, which is either blood or urine, in a charged electrical field, and all the proteins in the blood and the urine, they sort of move according to their charges. The immunoglobulins we talked about that is overproduced in myeloma, and I'm going to use my laser pointer here, they tend to accumulate in this gamma region of the electrophoresis electrophoresis chart. The gamma spike in a normal non-myeloma sample is a small hump. However, for someone who has an overproduction of immunoglobulins, they form this sort of red spike in that gamma region, and that is what we often refer to as the M spike. The M stands for monoclonal because it's one single type of antibody that's being produced. So the M spike is almost always abnormal, and the M spike is our first indication that there is something wrong. So once we have the M spike, what it tells you is that there is a monoclonal protein, but it does not tell us what kind of monoclonal protein it is. For that, we send something called as an immunofixation, which again can be sent in the serum as well as the urine. And that test actually kind of tells you what is the exact kind of monoclonal protein that the body is overproducing. We use antibodies to characterize the type of monoclonal protein, and it yields a result to us saying, is it IgG kappa? Like what's the heavy chain component and what's the light chain component, etc. So we have a full picture using the immunofixation. Quantitative immunoglobulin is another test, which again, we check to see the total number of immunoglobulins which is circulating inside the body. In a normal composition inside our body, the majority of antibodies are IgG, which comprises of 80%. IgA, which is found in all our surfaces, like the tears, the saliva, the mucosal surfaces, comprises of 15%. IgM floats around in the blood for 5%, and IgD and IgA are very less than 1%. And this is how a normal composition is there in a non-myelomatous state. In multiple myeloma, again, there is this overproduction of antibodies, and these can have very high levels of a single antibody that can be measured by this quantitative immunoglobulin level. For example, a serum IgG level can come back as over 3,000, whereas a normal level is 700 to 1,600. So this will help us determine what is a subtype of antibodies, and along with what we call a free light chain ratio, which gives us what is the type and what is the amount of light chains that are elevated, we finally have a diagnosis as to what is the kind of myeloma that we're dealing with. So the normal light chain ratio in the body is usually around 1, because the body kind of tends to produce equal amounts of kappa and lambda light chains. And the ratio of note can be slightly abnormal in those with chronic kidney disease or those who have an acute kidney failure. In myeloma protein, one or the other of the light chains will be extremely elevated, which skews the ratio to over 1. For example, if it's more than 3, that's again an indication that we could be dealing with something like multiple myeloma. In fact, and I'll come to this later, one of the diagnostic criteria for multiple myeloma is when the ratio is so skewed and so high that it's above 100, that's considered to be diagnostic of multiple myeloma by itself. We often assess for whether the patient who is presenting to us in clinic is symptomatic or not. The symptomatic myeloma, as physicians, we often like to have abbreviations and we like to remember them. So it's called the CRAB criteria for the longest possible time. And the CRAB the C stands for hypercalcemia, meaning a very high level of calcium in the body. And we have all these cutoffs that we look at based on which we decide whether it's high or not. So if someone has a high calcium in the body, if someone has a kidney dysfunction resulting in a very high creatinine level or a decrease in the amount of kidney filtration, and someone has anemia, if their hemoglobin is less than 2, or let's say someone used to be at a hemoglobin of 14 and it's now 11, meaning there's a difference of 2 from what they used to be. Or if we start seeing any bone lesions inside when we do like imaging, like X-rays, CTs, PET scans, MRI, any or all of these are considered to be signs of active myeloma. It's also very important that these symptoms need to be attributable to myeloma and that we don't have any other alternative explanation to what could be causing these symptoms. Now, there have been a lot of studies that showed that there were certain other very highly suggestive characteristics that predicted that certain patients would progress or certain patients would have multiple myeloma. So now, what we call myeloma defining events have been expanded to include a couple of other criteria, which is looking at the bone marrow biopsy and looking at the percentage of plasma cells. So the new criteria, what we often allude to, is called the SLIM CRAP criteria. The S stands for 60% of plasma cells in the bone marrow. If someone has a bone marrow biopsy and they have more than 60% of plasma cells, that is considered to be diagnostic of multiple myeloma. Same way, as I mentioned before, if someone has a light chain ratio of more than 100, that's an extremely high level of light chains in the blood. That's also considered to be a part of, that's diagnostic of multiple myeloma. When we do an MRI to look for any bone lesions, if we see more than one bone lesion, which is measuring at least 5 millimeters, that's again considered a criteria for multiple myeloma. So the SLIM CRAP criteria is what we normally use to try to see if the patient has active myeloma. There is a spectrum of disease when we talk about myeloma. So MGUS stands for monoclonal gammopathy of unknown significance. In this, the patient does not have any symptoms, meaning our CRAP criteria is negative, and they have a very small amount of protein called the M spike in their blood. And if you do a bone marrow biopsy, their percentage of plasma cells is less than 10%. MGUS is really not considered a cancer, but it is sometimes called as a pre-malignant state, because some people with MGUS will eventually develop cancers such as multiple myeloma, some forms of lymphoma, and even amyloidosis. The risk of progression is considered to be 1% per each year per person. The next phase is called smoldering myeloma. And in this phase, the patient has much more of abnormal proteins in their blood or their urine. When you do a bone marrow biopsy, they have a higher percentage of plasma cells in their bone marrow, anywhere from 10%, but less than 60%. But the patient remains completely asymptomatic. They do not have symptoms of high calcium, low hemoglobin, kidney failure, or bone lesions at all. When the patient has any of these active symptoms of CRAB symptoms, that is considered to be diagnostic of multiple myeloma when it is paired with an abnormal protein in the blood and when there is a higher than 10% of plasma cells in the bone marrow. Now, these are not values that as a patient or as a caregiver, you need to memorize. These are guidelines that we follow by, but this is just to give you a general idea of how we go about classifying whether someone has active myeloma needing treatment or if they are in an MGUS or a smoldering myeloma state needing active monitoring. There are other symptoms that we often associate with multiple myeloma, including frequent infections, hyperviscosity, meaning the blood can get really thick and cause symptoms like blurry vision, headache, nausea, vomiting, etc. Peripheral neuropathy, and also coagulopathy, meaning there's a higher chance of having blood clots in the system. Monoclonal gammopathy of undetermined significance, and the MGUS I was alluding to, while I did say it's not pre-malignant, there is a way that we are now looking at MGUS a little bit differently, in the sense that if there is a different type of heavy chain like an IgA, if there's a higher amount of protein in the blood, if the free light chain ratio is very high, these are all adverse markers that indicate that the patient could be at a much higher than normal chance of progressing to multiple myeloma. Similarly, for smoldering multiple myeloma, again, the patient is completely asymptomatic, but we have modern studies have now come up with risk stratifications through which we try to assess whether a patient falls into 4 categories. The 4 categories are shown in these plots that you can see here in the purple line, the green line, the blue line, and the red line, which are the high risk, intermediate risk, low, and the very low risk categories. And these categories, again, help us as physicians to determine what is the risk that a patient has of progressing at the 2-year time point and how often to monitor them in clinic. And if we think that they're at an extremely high risk, should we consider starting treatment early? There is, again, as with all cancers, there's a staging system that we often adhere to. The staging system considers some blood tests called beta-2 microglobulin, albumin, LDH, and also cytogenetics. And cytogenetics are the way we look at chromosomes when we do a bone marrow biopsy. So there are all these certain characteristics which together give us an idea whether a patient is at a stage 1, which is considered a low risk stage, stage 2, or stage 3. Again, these are clinical parameters that we look in clinic to identify who are the patients at risk, not something that patients need to completely focus on. So just in very broad strokes, what are the principles of treatment? How do we approach multiple myeloma? In these precursor or precancerous or asymptomatic myeloma state, the standard of care is still active surveillance. Like for patients who have MGUS or smoldering myeloma, we actively monitor in clinic and we refrain from giving any treatment. Now, suffice to say, there is a lot of research going on in the smoldering myeloma phase, in which we are trying to see whether treating a high-risk population early can have any better outcomes. But again, we do not have conclusive evidence yet, or that's an active area of research. It's very important to discuss with the patient, and we often do this in clinic, that we set the expectation that multiple myeloma is like an incurable disease at this point, and we often need some kind of therapy at most times for a patient for disease control. So the way we approach a patient is initially we see them in clinic. There are a lot of factors we consider, but one of the primary factors we consider is, are they eligible for transplant or not? Because if they are eligible for transplant, they usually follow one pathway of treatment, as opposed to if they're not eligible for transplant, they follow a different pathway of treatment, as you can see here. A patient who comes in, if they're eligible for transplant, receives a first series of treatment called an induction therapy, and this is followed by consolidation. What consolidation means is that we take the good response that is obtained by the induction and you consolidate or you cement it with a stem cell transplant, hoping that that good response will stay for much longer. And to make sure that good response stays for much longer, we put patients on what we call maintenance therapy. So again, starting off with induction, consolidate with stem cell transplant, and on long-term maintenance therapy until and if there is disease progression. And at each disease progression, which is indicated as relapse 1, 2, 3, 4, and refractory disease, we consider many different factors into selecting the best treatment possible. If someone's considered not transplant eligible, we often give one course of treatment followed by a continuous therapy, and then we address when the patient eventually relapses. So again, this is a very simplified approach to how we treat patients with newly diagnosed myeloma. Again, after a detailed assessment whether the patient is a transplant candidate or not, the induction therapy usually consists of a 3-drug or a 4-drug regimen called a triplet or quadruplet therapy. There are many, many nuances that go into a decision of whether a triplet or a quadruplet should be used, and the nuances of what kind of maintenance should be used. That's beyond the scope of today's talk. But just to give you an idea, we start with a 3 or 4-drug regimen, give a few cycles, harvest stem cells, and then do stem cell transplant if the patient's having a really good response. In another approach, you can give induction therapy a little bit longer and wait for a delayed approach to stem cell transplant. Eventually, you want to consolidate that good response you got out of transplant with what we call a maintenance therapy with either one agent or two agents. So that's one pathway we follow for patients who are transplant candidates. For a lot of patients who are not, unfortunately, candidates for transplant, we do induce them with, again, a three-drug regimen, but sometimes we refrain to 2-drug regimens if we think they cannot tolerate it. And this is continued often until disease progression. At the time of disease progression, there is a lot of factors we consider, like their performance status, meaning how can you function with your activities of daily living and how well you can take care of yourself at that time, the age, if there's any cardiac or renal or neurologic comorbidity that they have, disease factors, meaning are they high risk or standard risk, all the other exposures to the medications we have given them before, what was the duration of the initial response that we gave, and then also a lot based on patient preference. We have patients coming and saying that we don't want, sequential IV treatments. Can they go on pills? Their access, their access to like an institution that has access to all these medications, and also logistics of transportation. So a lot of factors go into how we decide to treat relapsed myeloma. A very brief overview of stem cell transplant. Stem cell transplant is usually done after that initial set of treatment called induction therapy. Stem cells are removed, and that removal process is called apheresis or harvesting from either the blood or the bone marrow. These harvested stem cells are concentrated, they're frozen, they're preserved, and the patient gets a high dose chemotherapy to destroy any remaining myeloma cells in their bone marrow. And these stem cells, the patient's own stem cells, are reinfused back to the patients, where they will repopulate the bone marrow and they'll hopefully grow back as healthy new cells. So this is, a very simplified overview of how a stem cell transplant looks like. This is a table that shows, truly how the field of myeloma has changed in the past many, many years. All these columns show different classes of medications that we use to treat a multiple myeloma. And as you see, there are at least 10 different classes of medications. There are 20 different agents that we can use. I have grayed out some medications which have recently lost their FDA approval, and the italicized ones are those who don't have active FDA approvals yet. But these are all available at clinical trials in many, many centers. So it truly is an embarrassment of riches. However, we're still a long way to go from having like a very strong and potential cure for myeloma at this time. But I just wanted patients to have this idea that this is the arsenal of treatments that we have at our disposal to help you. Cellular therapies, now just switching gears to cellular therapies can be any, we take a cell from a patient and we genetically modify, or we don't genetically modify. And there are many kinds of cellular therapies. However, for the purpose of today's talk, I'll just focus on what we call chimeric antigen receptor, T cell. And there is also NK cell chimeric antigen receptor, which are now studied for multiple myeloma. It's of importance to note that there are now 2 FDA-approved autologous, meaning from the same patient, CAR-T therapies that are available for patients in various centers. One is called idacaptogene vicleucel or Idacel, and the other is ciltacabtagene autoleucel or called Carvykti. They both target the BCMA protein on the surface of these plasma cells, and they are found to be very efficacious therapies, which are actually a godsend for patients who have seen 4 or more lines of treatments and have good responses. There are other promising candidates which are not FDA approved and they're still in the clinical trial stage, with new targets like GPRC5D, taking a CAR-T from a healthy patient and giving it back to the patient, which is called allogeneic CAR-T and also CAR-NK. Very quick overview of how exactly are CAR-T cells made. So blood if you imagine it to be very similar to stem cell transplant, you won't be far off. In fact, we collect blood from a patient over 3 to 6 hours. The white blood cells are separated and the remaining is reinfused back to the patients. The difference is that the T cells then go to a laboratory. These T cells are genetically modified to express, and I'll use my laser pointer again, to express this little receptor on the surface of these cells, which can identify the target that we want. The CAR T cells then multiply in the lab, and the whole process takes around 1 to 2 months. And then they are reinfused back to the patient after lymphodepleting chemotherapy. These CAR cells, which now have a new receptor to identify the cancer cell, then goes and binds to the cancer cell and kills them. So this is a nutshell of how the CAR T cells function. So right before treatment with the CAR T, we often give chemotherapy, and we also give medications to suppress any kind of responses you have, like fever or allergies, etc. Cellular therapies, they're very efficacious, but they're not really benign. They have what we call short-term and long-term complications. The short-term complications are cytokine release syndrome, and it can also have neurotoxicity, which we closely monitor in the hospital setting. There are long-term effects too, called macrophage activation syndrome, B-cell aplasia, and prolonged cytopenias, which we monitor very closely in clinic. Other complications of myeloma, which we actively look for and manage, include bone health for pathologic fractures, bone pain. The kidneys are very important to us because it determines what's the kind of dose we give, infections, hypercalcemia, anemia, neuropathies, etc. So there's a whole host of complications for which we both have treatment, and we also give preventative medications as well, which is summarized in this table. And with that, and I think I'm slightly over time, I just wanted to highlight that Multiple Myeloma Awareness Month is coming up in March. And we're happy to have any questions. And the advances in our field will actually be discussed by Dr. Shaji Kumar, who is coming in just a few minutes after. So please stay tuned for that. Thank you so much for your attention.
Thank you so much, Dr. Rajiv. That was awesome. A great primer on understanding this complicated disease. And again, we're going to have a panel discussion after the next talk where we can answer some questions regarding the presentation. But next up, we have Dr. Zhang she's from my University of California, San Diego. She's in the division of blood and marrow transplantation. I work with her closely. She's one of our outstanding new physician and part of our team. And I look forward to her talk. She's going to break down a diagnosis, acute leukemia, that is an emergency of a diagnosis that we see all too common, unfortunately, in our hospital. And she's going to go over acute leukemias and some of the latest advances in the therapies for these diseases. Go for it, Autumn.
Thank you very much, Dr. Goodman, for that introduction. All right. Okay. So good morning, everyone. My name is Autumn Zhang. I'm one of the assistant professors in the Division of Blood and Marrow Transplantation at UC San Diego. And it's my honor today to speak to you about small molecule target therapies in acute myeloid leukemia. I have no disclosures. So this is the outline of today's talk. First, I'm going to go over what AML is and our way to personalize medicine by genetic testing in acute myeloid leukemia. Then I'll go through the FDA-approved small molecule targeted therapies for newly diagnosed AML and also relapsed refractory AML. And these are the drugs that I will be talking about. And lastly, we'll touch on the future directions with new exciting therapy options. So can one master key open all locks to AML? And that is what used to be our treatment strategy, where we take one chemotherapy and give it to everyone. However, we all know that that's not efficacious for everyone. All locks are unique, and so is everyone's AML. So we must individualize our keys and our therapy options to unlock all the AML, different types of AML. And this is what we call personalized medicine, individualized treatment options to everyone's unique leukemia. So today, I'm very excited to discuss the targeted therapy in AML, and especially the small molecules, which is the first step to personalized medicine. So to understand that, we'll have to go to the basics and talk about what is acute myeloid leukemia and how does it happen. So in our bone marrow, which is inside our big bones, like our hip bone or our leg bone, is an organ called the bone marrow. And the bone marrow is a factory for all of our blood cells. The red blood cells that make our blood red, carries our own oxygen, the platelets, which help stop bleeding when there's a cut, and the white blood cells, which are our immune system. And these blood cells all come from a stem cell. A stem cell is a baby cell, and these baby cells grow into different types of adult cells. A particular type of stem cell we are interested in AML is this myeloblasts. These myeloid stem cells, and when they commit into a lineage, grow into a myeloblast, which arise to white blood cells. But when there is an insult to that myeloblast, and that is when acute myeloid leukemia develops. So in a normal cell, when there is an insult or a DNA mutation, when there is an unfixable DNA damage that happens, then normally these cells will activate mechanisms to die. But in a cancer cells, there is a DNA insult or mutation that has prevented the cells from dying. And unfortunately, instead of dying, they start growing and dividing. And when that happens to a white blood cell, that's what we call a leukemia. If that happened to a lung cell, that would be a lung cancer. If that happened to a breast cell, that would be breast cancer. And that happened to the myeloblasts that we looked at just before, and develop into acute myeloid leukemia. So what did happen in this mutation? And when your doctor says that we're waiting for these fancy molecular testing on the leukemia, this is what we mean. We're trying to characterize individual AMLs with FISH testing, karyotyping, and next generation sequencing. These are all very fancy tests to look at what types of mutations and genetic characteristics the leukemia has. And this becomes very important because these genetic characteristics will define the subtype of AML. And this is just recently updated last year. And as you can see here, there are many, many different types of mutations and gene abnormalities that gives characteristics to each and different AMLs. And in the bottom here is the different types of subtypes of AML. And to name a few, there will be AML with recurrent genetic abnormality, AML with mutated TP53, AML with myelodysplasia-related gene mutation, AML with myelodysplasia-related cytogenetic abnormality, and AML not otherwise specified. And these are all defined by that genetic characteristics. Also, these genetic characteristics are prognostic. They tell us about how aggressive the leukemia may behave in the future. And broadly, we have three risk categories. These are also updated last year by the European Leukemia Network. And we've categorized them into favorable risk, which is about 35% of all new AML, intermediate risk, which is about 25% of all AML, and adverse risk, about 40% of all AML. And as you can see in the table, these abnormalities are unique and also very complex. So this is an algorithm of how we treat patients with AML. And it's very important to learn this genetic characteristics because it's important in therapy selection. As you can see here, depending on what type of mutations you have, we have all these different therapy options. And also in those who have their leukemia come back, relapse, depending on the mutation status, for example, the FLT3 gene, IDH gene, we have different types of medications that can target these mutations. These targeted therapies provide individualized treatment plans. And there are some targets in the blue here that are not, you don't necessarily need a mutation and it can be targeted for everyone. Whereas in the red, you need that specific mutation to be present so that we can target with a particular drug. And the goal is that these cancer cells stop dividing and either die or they do their normal thing and grow into an adult cell. So now that we talked about the genetic testing in AML, let's talk about what therapy options there are for new and relapsed AML. First up is venetoclax. This is a very exciting new medication that was approved in 2020 for AML. And BCL2 is a target of venetoclax. This is active in almost all AML, regardless of the mutation status. And this small molecule, which is probably about 100 to 1,000 times smaller than the COVID virus, goes into the cancer cell and blocks the protein called BCL2. And when that happens, instead of the cancer cells growing and growing, they do their normal routine, what it's supposed to do, and they die. So in this big study called VIAL-A, patients who were deemed to not be able to undergo intensive chemotherapy were split into two groups. One group got a medication called azacitidine and a sugar pill, a placebo. The other group got azacitidine plus venetoclax, which is targeted therapy for BCL2. And this is what we called a survival curve. This is the proportion of patients who are alive at this particular months. And the top one is better because that means that more people are surviving, more people are alive. So the top curve is azacitidine plus venetoclax, whereas the bottom curve is the patients who got the sugar pill. And you can see that there was about 5 months improvement in survival when we added the venetoclax to the azacitidine. This led to the approval of this combination, azacitidine and venetoclax, in newly diagnosed AML patients. Another medication called midostaurin is a target. It targets a protein called FLT3. And there are two types of FLT3 mutations, ITD and TKD, and this midostaurin targets both. This mutation occurs in about 25 to 30% of all AML patients, so it's a very attractive option. This medication was studied in combination with intensive chemotherapy, our usual, which is called 7+3. Anyone who had the FLT3 mutation and had newly diagnosed AML who hasn't had any treatment yet were then split up to two groups. One group got the chemo plus placebo, a sugar pill. The other group got chemo plus midostaurin. And just like the other curve, as we saw, the top curve is a better one. There are more patients surviving. So the midostaurin improved the median overall survival, so the length of survival, by about astonishing 50 months. So this again was approved by the FDA, I believe in 2018. And this is FLT3 mutation is a routine test we send for everyone with newly diagnosed AML so that we can add on this medication if someone possesses this mutation. Now, switching gears to our relapse and refractory AML. I want to first touch on a mutation called IDH. There are two types of IDH mutation, 1 and 2, and they both occur in about 5 to 10% of all AML patients. So that's a sizable portion. This mutation blocks the stem cells or these myeloblasts, the leukemia cells, to maturate or to grow into adult cells. So those are all the X's that we see. And they just divide, and that's how the leukemia happens. But when we block the mutated protein with this medication, ivosidenib, olutasidenib, or enasidenib, then these leukemia cells are able to grow into the adult cells. And now we have normal adult cells growing. So this particular mechanism of how this works, how this medication works, brings on an interesting and sometimes very devastating side effect called differentiation syndrome. That's what we usually monitor for very closely when starting these treatments. So I have examples of ivosidenib and enasidenib here, where we see the overall response rate, meaning people who have responded and benefited from the therapy, were about 40% of all patients who were treated with just this medication. And in about 20% of the time, people had a complete response, and that's what CR means, complete response, where we were able to get rid of the leukemia. So ivosidenib and enasidenib are now approved for patients who have those particular mutations in AML. Olutasidenib was just approved about 2 months ago for patients with IDH1 mutation. And note that ivosidenib also approved in the first line setting where people were not treated ever and were newly diagnosed. And that was also very recent. Lastly is the FLT3 inhibitor, gilteritinib, and also in patients who had their leukemia come back and had a FLT3 mutation in their leukemia. They were taken into two groups. One group got the gilteritinib, that's a FLT3 targeted therapy. One group got other types of chemotherapy. And as you can see in this chart, the patients who had the targeted therapy had about 4-month improved survival compared to those who had conventional chemotherapy. Again, a remarkable achievement with just a pill, because and the other good thing about these targeted therapies are that they're all pills. The venetoclax, midostaurin, gilteritinib, they're all pills that we can take at home. This also led to the approval of gilteritinib in those people who have FLT3 mutated acute myeloid leukemia that had their disease come back. So lastly, we'll briefly touch on the future directions of acute targeted therapy in acute myeloid leukemia. These are just an example of the targeted therapies that are under study. So there are many that are undergoing clinical trials. And there are many exciting new targets, such as CD47, which is a protein that's on the cell of the AML, or TP53, which is a very important protein in cancer biology. We're also looking at if we can get more effective inhibitors than what we have right now. Another very exciting area, which is still not ready for prime time, but the CAR T-cell therapy, the bispecific T-cell engagers, and antibody drug conjugates are all types of new therapies for AML. We're also investigating whether we can combine these targeted therapies with what we have right now, so triplets, adding on medication to what we have. Lastly, maintenance therapy, where after all the treatment is completed, should we put people on some type of pill for a long time to keep the cancer undetected? So those are all on the horizon right now. So with that, these are my references, and I would like to thank you for your attention.
Thank you, Dr. Zhang. That was an excellent discussion on acute myeloid leukemia. So now we have a little bit of a panel discussion, and I'll start with Dr. Rajiv first. So with myeloma, you know, I've been in practice for 5 or 6 years since fellowship, and I mean, the field's exploded. It's amazing how many new drug approvals we have, which is great for our patients. And I think now we're entering the era of immunotherapies in myeloma, specifically the CAR T cells and the bispecifics. And just to reiterate the difference, because these things are confusing even for physicians. So CAR T cells, as Dr. Rajiv discussed, these are where patients, their own immune cells, their own T cells are collected from the patient. So it's a procedure, they got to collect them. They then send them to a lab where they're modified to attack the cancer cells. And then we have another class of therapeutics that work similarly, but are different, which are called bispecific antibodies. And there is now one approved just a few months ago now for myeloma called teclistamab, which is great for our patients. And this drug works by basically bringing the T cell, the patient's own immune cell, to the cancer cell. So it brings them together. It doesn't modify the T cell, brings them together. Both the CAR Ts and the bispecifics work really well in patients. So Dr. Rajiv, how would you have a patient in front of you who, is in need of one of these therapies. What are some things that go through your mind in selecting CAR Ts versus bispecifics for the given patient in front of you?
Yeah, absolutely. I think, it also well, first of all, I think these are both very efficacious therapies, which in patients who have seen multiple lines of treatments we have at this time point. So when assessing whether a patient is a candidate for CAR T versus bispecifics, I think the institution's access to these medications would be a consideration, whether the patient's disease is like kind of behaving, whether it's stable versus if they need treatment right away. They may not be like, we may not have the time to collect their cells. We may not be able to effectively bridge them and then give the CAR T cells back. So in such a patient, especially with now commercial teclistamab available, I think I would be very, encouraged to use teclistamab for disease control. If someone is a patient, if someone's a candidate for CAR T, their disease is progressing, but the kinetics of the disease is not extremely rapidly explosive, I think that's a patient I would consider collecting, giving a cycle or two of bridging therapy, and giving back. It also depends on how I think the patient, by the time patients are eligible for CAR T or bispecific, their follow-ups and how they tend to be. Bispecifics tend to have like a continuous manner of infusion. CAR T is like a one and done, and you can give them like a nice window of treatment-free time. So access, their disease status, all of these will go into consideration, I would think.
Yeah, no, those are perfect points. And I think, like they both have we don't know what's better. They haven't been compared. Hopefully one day, maybe they will be. But at this point, we have no head-to-head comparisons of the two. So really, the CAR T, the pro, at least for me as a physician, especially who treats lots of myeloma, and if you have myeloma, you're on therapy for long periods of time, sometimes for years without treatment breaks. And the CAR T cell is a one and done therapy, although very intensive therapy, usually requiring a few days of hospitalization. But once you're done with the procedure, it can be years if you look at some of the data on our newest CAR Ts for that. Whereas teclistamab, the bispecific, it is something that is given continuously. At this point, we don't know yet if you can stop it. So that is something. And I think, even with the bispecifics, they're drugs that are not like CAR Ts, but I do think there's a learning curve to giving those drugs too. I'm spoiled, I'm at a cell therapy center and we do transplants. So we have all the infrastructure in place to deal with these types of therapies. So I think there's going to be a learning curve in the community. It's not that they're not capable, they just haven't done these things yet. And ideally what I see, I think best for patients who don't have immediate access to academic centers will probably be maybe starting a bispecific at an academic center, which is usually first round of the bispecific is usually where the most toxicity is. Actually, it's almost all of it is going to happen with that first or second dose, and then continuing the therapy outpatient with their local physician. I think, again, though, it's going to be a lot of communication, and hopefully we'll get better at this as we progress. So again, all hard things. And I think another thing with CAR T, in my opinion, is, you have to be well enough to get the CAR T and do well for a few months, we got to cook the CAR T. It's not out of the package like the bispecific. So, even at our center, we're pretty fast. It can be a few months before a patient, they see me and I go, you need a CAR T cell. It's still going to be 8 weeks maybe till they actually get that CAR T cell. So for patients with explosive disease that need rapid treatment, it's not sometimes the best option. So these are things that physicians are thinking about when we're dealing with patients in our clinics being evaluated for these therapies. So it's great to have all these therapies, but it's making our job tougher. But it's good that it's tougher. So
quick question about your practice. Do
Yes.
you ever think of or in the sense that what are the costs that we are incurring for CAR T versus bispecifics? I mean, it's very hard to estimate, but then CAR T is, again, you come, get admitted, get your CAR T, and then it's follow-up. But bispecifics, as of now, it's continuous when studies of a definite therapy are only ongoing. So again, when choosing disease kinetics apart and other considerations apart, do you ever think of the financial implications? And also, would you ever move to a completely outpatient administration?
Yeah, so we're so first, as far as costs, and costs are very important to me, but it's hard with the patient in front of you. It's hard to let cost be a factor when they need these therapies. And as of now, our process at UCSD is no patient's paying out of pocket for a CAR T. They don't make it that way through the approval, because no one can pay $500,000 for one of these things, which is, I believe, what it costs. And with teclistamab, I've so far prescribed it now once for my own patients. It just was approved, and again, it's mega expensive and the insurance is paying for it. So yeah, they may have a high deductible and they'll go through it pretty fast. So but again, and that's just a sad state of where our cancer system is. Patients who need these therapies, they need these therapies, and they're willing to do, in most cases, what it takes. So and I think that physicians to figure out better ways to advocate for our patients and try to cut down costs and work on clinical studies that address these things. So in the final few minutes we got to discuss, let's talk about acute leukemia, a little bit of a change of pace. And, Dr. Jong, you went through, really, again, when I was a fellow, we treated, acute leukemia with 7+3, and literally and that was the board answer for treating acute myeloid leukemia. And now there's multiple new drug approvals, but with these pills, I think I want to talk a little about allogeneic transplant. So Dr. Jong, are these pills, they're beneficial, but are they curing patients, these pills?
And the short answer to is unfortunately no.
Yeah. So the IDH1, IDH2 inhibitors. So unfortunately for the majority of patients diagnosed with acute myeloid leukemia, they're older, over the age of 65, and will have features of their AML that put them at higher risk. And, I think that it's worth talking a little bit about, I personally feel strongly, now I'm biased, I'm a transplanter, but I think it's important, especially if patients treated in the community, that anyone with newly diagnosed acute myeloid leukemia, once they're out of the hospital, should have a visit with a stem cell transplant physician to at least discuss the role. And, Dr. John, can you go over just at our recent conference, there's a lot of myths about transplant and risks, but with serious complications like graft versus host disease, but we're actually getting much better with our preventative strategies to prevent graft versus host disease and reduced intensity platforms. And again, these therapies are potentially curative to the disease. So Dr. Zhang, where do you fit transplant? How do you approach that with some of your patients, the role of transplant in acute myeloid leukemia?
Yeah, that's a very excellent question and a very hard one too.
Yeah, that was a long one. Good luck.
Because first of all, as Dr. Goodman alluded to, the transplants can be toxic. And I often run into a situation where unfortunately, the patient population in acute myeloid leukemia are those who are on the older side, maybe in their late 60s, early 70s, or even older. And that's the group that the transplant discussion is the hardest, where I am worried about the side effects of the transplant, the graft versus host disease, all the chemotherapy, the cytotoxic chemotherapy they are going to get. But potentially that is the only curative option for them, especially if those for those patients who are at high risk, or for those patients who had their leukemia unfortunately come back. Now I think those are the situations that we discuss transplants exactly. The patients who are at high risk disease by that risk category, the favorable, intermediate, and the high risk, and those people who had leukemia come back. So that's where I do my discussions of transplant. Oftentimes it becomes a very long, complicated discussions about what the risk and benefits are.
Yeah, and in the final few minutes, we're seeing CAR T cells in lymphoma. We're seeing CAR T cells in myeloma. CAR Ts in multiple lymphoma types, follicular mantle, DLBCL. They're in development for CLL. We're seeing CAR T cells in acute lymphoblastic leukemia that are approved. Where are we in AML as far as cellular therapies outside of transplants? And what are some of the issues potentially, because AML, we're behind with cellular. What are some of the issues that you're seeing, and where are we in the development?
Yeah, there are many, exciting clinical trials going on right now with cellular therapy and AML. There are many multiple targets that we're assessing that have exciting preliminary results, but they're far from being mature yet. I'm hoping that in the next 1 to 2 years, we'll be able to have something available for our patients. Right now, they're not ready for prime time.
Yeah, the problem with AML is, so with these CAR T cells and these bispecifics, these immunotherapeutics that are so potent, you need to have a good target. So, the targets in myeloma and lymphoma, we give these CAR T cells, they get rid of all the cancer cells with that target, but any healthy cell that has that target will also be eliminated, okay? And with myeloma, there's issues, but patients can do okay without their plasma cells. We can give them IV, we can give them replacements of antibodies. They are at high risk infections. Same with lymphomas. The problem with AML is the targets on the AML cells are also on very, very important early healthy stem cell blood cell types. And they're also shared on the lining of our blood vessels and in our liver. So if we give a CAR T to an AML target, it might kill all the AML, but we'll have what we call on target, but off tumor toxicity, meaning the CAR T is hitting what it's supposed to hit, but not where you want it to go. You don't want the liver to be inflamed after a CAR T. So those are some of the issues that we're seeing with acute myeloid leukemia. And just as 10 to 15 years ago, treating melanoma was impossible, I have full faith that, and now we can cure a lot of those patients. I have full faith that investigators, both the clinical investigators and our scientists, will figure it out. I mean, the pace the field's moving, we're just not there yet. And that's some of the hurdles that make treating acute myeloid leukemia a little bit more difficult with cellular therapies. Okay, and I think, did I do well on time? Yeah, so we are going to, I don't know if our Grace is there, but I think we're going to move on to our next section. And the next section is with Dr. Zhang, and she's going to be talking about geriatric topics in geriatric lymphoma. Okay, and Dr. Zhang is a hematologist oncologist at the Mayo Clinic, and she specializes in the care of lymphomas and chronic lymphocytic leukemia. She has clinical research in the intersection of geriatric and hematology and supportive care, a very difficult field. Blood cancers are aggressive, and in a population of older adults, it makes things even all the more difficult. And that's her main research interest, in trying to figure out how to improve decision-making and patient-reported outcomes in this difficult space. And so I'll leave it to her. We'll still start her talk on topics in geriatric lymphoma.
Great. Well, thank you so much, Dr. Goodman, for that introduction. And thank you all in Grace for inviting me to speak to you about special considerations for older adults with aggressive lymphomas. Okay. So first, I'll review why older adults require more nuanced care. Then I'll talk about the geriatric assessment tools to help identify individual level syndromes and conditions in older adults. And then I'll review some of the landmark lymphoma studies that tailor chemotherapy specifically to older adults. And lastly, I'll review some health modifications that anyone can make to improve their survival from lymphoma. So older adults need thoughtful and nuanced care. They're underrepresented in clinical trials, so we cannot directly apply trial results to them. And they often have comorbidities that place them at high risk for complications from treatment. They have logistical concerns, which can make it difficult for them to complete certain therapies. So, for example, some of the lymphoma treatments require caregiver support for frequent visits and lab monitoring, as well as monitoring at home for any side effects or complications like infection. Now, I'm showing this figure to demonstrate that older adults with cancer are complex. Their care can require an interdisciplinary team to address unique concerns. So, for example, looking at geriatrics, oftentimes if people are feeling well and they don't have a lot of other uh, concerns, a geriatrician is fine to help co-manage with an oncologist. But for people who have a huge symptom burden from their disease, or if they have a lot of complex decision making that needs to be done, then a palliative care physician can also be helpful in conjunction with a geriatrician and oncologist. And this figure illustrates how the body changes with aging and what this can look like. So, for example, in the brain or the central nervous system, there can be a loss of some of the mechanisms that allow the nerves to communicate with one another. And this can result in issues of weakness and increased risk of falls. So, our treatments in cancer care need to adapt to aging bodies. So, the geriatric assessment is really an umbrella term to encompass multiple tests that assess different aspects of life. So, these include, for example, function and ability, which is how an older adult can complete their day to day activities. Disease severity and comorbidities include different medical conditions that older adults can have in addition to their cancer. Mental health and cognition really focus on whether people have depression, anxiety with their cancer care, um, or memory loss, as well as their level of support. So, do they have family or friends nearby, neighbors? Who is their support network? Additional evaluation on top of this includes evaluating nutrition, medications, and how they can interact with chemotherapy, and the environment in which adults live. So, is it safe? Do they have a lot of stairs at home? What's their bathroom situation look like? Now, using multiple geriatric assessment tools provide a holistic understanding of older adults. And I'm showing one of the most commonly used tools that evaluates someone's ability to function in their day-to-day activities. It's called the Activities of Daily Living, and we divide it to basic and instrumental or independent activities of daily living. The basic activities of daily living really focus on self maintenance. So, are you able to feed yourself, drink, go to the bathroom by yourself? And then the independent or instrumental activities of daily living focus on how well someone carries on functions that require more attention and effort, such as grocery shopping, doing chores, cooking, and handling finances. The cumulative illness rating scale is a scale that was used in some of the clinical trials, and they have one specifically for older adults. And it goes through someone's entire body system and has that individual rate their level of impairment or their level of disease in each category. And based on that, we can understand whether someone would be categorized as being fit for treatment or unfit. A physical exam tool that I like to use in my clinic is something called the timed up and go. And the timed up and go helps me assess how well someone walks and whether there's any issues with their balance. So, what I do is I have patients get up from a standing position or a sitting position, and they'll stand. And so I watch how they stand and how long it takes them to stand up from a sitting position. Then I have them walk about 30 feet. So definitely across the entire room, turn around, and then walk back and sit in the chair. Now, a normal test is less than 12 seconds. However, research has shown that if someone takes longer than 20 seconds, then this is a sign that they could be dealing with issues of frailty. Now, this is really important because the geriatric assessment has astounding impacts on care. So here I am showing data from one of the largest clinical trials looking at geriatric assessment. So this is a randomized clinical trial of 718 older adults across 40 clusters of community oncology practices in the United States. And they had solid tumor malignancies as well as lymphoma. So this study compared a geriatric assessment intervention with the usual care and evaluated the rates of chemotherapy-related side effects. Now, the intervention was that the oncologists who treated these patients received a tailored geriatric assessment summary and management recommendations. And the participants who received this intervention had lower rates of chemotherapy side effects or toxicities. So, for example, if we're looking at any toxicity here, in the usual care arm, 86% of adults experience any toxicity, compared to 64% who received the geriatric assessment intervention. So when you do the math, this means that 5%, or excuse me, 5 people need to have this intervention, this geriatric assessment intervention, to reduce side effects for one person. That's really remarkable. So for the interest of time, I'm going to review only select landmark studies to illustrate how we tailor first-line treatment for advanced stage aggressive lymphomas. And I just want to put a disclaimer that some oncologists might suggest different therapies from this. And I think that there's really no right answer, but I just wanted to show that there are ways that we are thinking as oncologists about how to adapt chemotherapy to aging bodies. So I'll discuss both non-Hodgkin and Hodgkin lymphoma. So as a background, lymphoma is a cancer of a very specific type of white blood cell called lymphocytes. And lymphocytes are an important part of our immune system, and they live within the lymphatic system and the spleen, which helps to filter blood. And so as you can see here, you have lymph nodes all throughout your body. Lymphocytes are also in the bone marrow, so they're made in the bone marrow, which makes blood cells, as we learned from Dr. Zhang. And the main difference between Hodgkin lymphoma and non-Hodgkin lymphoma are these cells on the left, which are owl-eyed, and they're called Reed-Sternberg cells. So if the Reed-Sternberg cell is present in the lymphoma, then it's called a Hodgkin lymphoma. And if it's not, then it's non-Hodgkin. And there are over 50 subtypes of non-Hodgkin lymphoma. So the most important part of lymphoma treatment is getting the diagnosis correct, because then we can really address the cancer with the right therapies. The other important factor about lymphoma is staging. So this is the Ann Arbor staging system, which illustrates how widespread the lymphoma is throughout the body. So advanced stage refers to stage 3 and stage 4. And stage 3 just means that lymphoma is present above and below the diaphragm. And stage 4 means it's in an organ outside of the lymphatic system, like the bone marrow or other parts of the body. And unlike solid tumor cancers, such as lung cancer or colon cancer, some stage 4 lymphomas can actually still be curable. So I'll first review treatment of Hodgkin lymphoma. Now, Hodgkin lymphoma affects 2 main age groups. So people in their 20s to 30s, and there's a second peak for adults over age 60. And the reason there's a lot of studies looking at older adults with Hodgkin lymphoma is that a lot of the older adults with Hodgkin lymphoma present with advanced stage disease at the time of diagnosis. They have a lot more comorbidities and they have more aggressive disease at baseline. So we really need to figure out the best regimen for older adults, because oftentimes the regimens that are used in people who are in their 20s to 30s can be quite toxic. So as I mentioned, your oncologist may prescribe different regimens from what I'm listing here. And the purpose of these next sets of slides are to review the data from trials that are specifically in older adults. So the standard treatment that we use for Hodgkin lymphoma, as I mentioned, is often ABVD. It's can be quite toxic. That B is bleomycin, and has an increased risk of lung toxicity, especially in older adults. So as people age, that risk increases. And this is really due to a difference in age, biology, and tolerability. So in the last decade, there have been a lot of studies that focus on how to tailor therapy. So first, the geriatric assessment has been used in many of these studies, and it helps people to determine whether someone is fit or unfit for treatment. And then if they're fit, then they'll go on for a very prolonged chemotherapy course, versus unfit, where they might get single agent chemotherapy or combination with immunotherapy. So I'll review each of these in detail. But before I go into the actual studies, I wanted to highlight some definitions that I'll be using. So overall response rate is the percentage of people who had at least some response to treatment. Partial response is defined as at least a 30% decrease in the size of whatever cancer lesion we're targeting. Complete response means that all the cancer disappeared. Overall survival is from the time of randomization on the clinical trial to the time of death from any cause. And progression-free survival is a time from randomization on the clinical trial until there was some objective tumor growth. So for fit patients with advanced Hodgkin lymphoma, there was a phase 2 study of sequential brentuximab vedotin and AVD. So in this study, the participants received 2 cycles of AVD, and the response rate to this was 82%. And actually, 36% of people had a complete response after those 2 cycles. So this was followed by 6 more cycles of AVD. So that's another chemotherapy regimen. And this had increased the overall response rate to 95% and a complete response to 90%. Then brentuximab vedotin was given for another 4 cycles. And overall, 95% of people had an overall response rate of, had some sort of response to treatment. And 93% of people had their cancer go away completely. Now, the main issue with this regimen is tolerability. It is a very long regimen. And what the researchers have found is that when people were considered unfit by that cumulative illness rating scale I showed you earlier, they had a harder time tolerating the therapy and completing the therapy, and they were more likely to have progression, meaning the cancer came back after treatment. Now, for people who are considered unfit, there was a clinical trial that resulted in 2 different publications where patients who were 60 and older had either single agent brentuximab vedotin or brentuximab vedotin combined with some other agent. And for people who received brentuximab alone, the overall response rate was 92%. So of those individuals, 73% had no evidence of cancer. And the amount of time until objective growth of that cancer, or the progression-free survival, was 10.5 months. Now, when you add dacarbazine to brentuximab vedotin, you get a similar overall response rate of 100% actually. So everyone responded. And then the complete response was a little less than single agent rituximab vedotin, so 62%. However, you get a deeper response, a deeper remission. So it took 17.9 months for people to have any sort of objective growth of their cancer. And then the third arm had an even better response. It's brentuximab vedotin and bendamustine. But unfortunately, 65% of participants had some serious event and there were 2 deaths. And so this arm was actually discontinued on the clinical trial. Another option, which I had highlighted in the initial slide, was brentuximab vedotin and nivolumab. So nivolumab is an immunotherapy agent that is used, and they studied it in first-line therapy for adults who are 60 and older, or people who are considered unsuitable for standard therapy because they had impairment of their heart, lung, or kidney function. Now, the median age was 71.5 years, with a range of 64 to 77 years. And of the 46 participants, only 2 were younger than 60. So they received 8 cycles of treatments, and 64% of people had some sort of response, with 52% of people responding completely. The main side effects were related to the brain and the spinal cord, or neurotoxicity, as well as numbness and tingling, or neuropathy. And then 1 person died from a cardiac arrest, which may or may not be related to the treatment itself. Now, shifting gears to a type of non-Hodgkin lymphoma, which is diffuse large B-cell lymphoma, the main regimen that's used is called R-CHOP, which I highlight here. And R-CHOP can be challenging for people because it can affect the heart function due to this doxorubicin. And it can cause bone marrow suppression, so people can have issues with making white blood cell counts. And so this study looked at decreasing some of those toxicities by reducing the doses of chemotherapy. So in this phase 2 study of adults 80 and older with diffuse large B-cell lymphoma, they gave reduced dose chemotherapy. So as you can see, I'll highlight here the dose reductions to 150 adults. And overall, 73% of people had some sort of response, with 62% of people having their lymphoma go away completely. And this effect lasted for a median time of 21 months. The caveat with this is that there were 12 deaths due to toxicities from the regimen. And about 40% had some severe neutropenia, meaning their white blood cell counts were so low, with 7% of them having to be hospitalized for fever. So this follow-up study was designed to help reduce some of those deaths and treatment-related side effects. And what they did was they replaced rituximab with ofatumumab, and they gave something called pre-phase treatment, meaning 1 week before therapy, they gave steroids and one of the chemotherapy drugs called vincristine, in addition to the chemo. Similar study design otherwise, with adults being 80 and older. And what they found was when they gave this treatment, there were no deaths due to treatment toxicities. The most common cause of death was lymphoma. And they were able to reduce the neutropenia, so the low white blood cell count problem, by 50%. So only 21% of people had this neutropenia. The same rate of people were still hospitalized, though, for, we call it febrile neutropenia, or fever in the setting of low white blood cell counts. So based on this data, I actually give steroids before a week before treatment for select patients. Now, in the remaining minutes, supportive management, this is really focused on the question of what can I do as a patient to help improve my survival. So the first thing is vitamin D deficiency. I screen my patients for vitamin D deficiency, or I tell them to take vitamin D, because there are multiple studies here that show that vitamin D deficiency is associated with the worse survival, both progression-free survival, so time to growth of the cancer, and overall survival. And this is seen in non-Hodgkin lymphoma, Hodgkin lymphoma, NKT cell lymphoma, mantle cell lymphoma, chronic lymphocytic leukemia, any sort of stem cell transplant, and CAR T cell therapy. So it doesn't hurt to take a vitamin D supplement. And I encourage everyone to be physically active. So in several studies, physical activity after lymphoma diagnosis actually improved overall survival and lymphoma-specific survival. There's a group in France that's currently conducting a phase 3 trial evaluating physical activity. And this data has not yet been published, but I'm looking forward to it. So on the CDC website, they actually go through examples of how to increase activity if you're an older adult. So you could either walk for 150 minutes a week, or jog for 75 minutes, or do a mix at least 2 or more days a week. And then do some muscle training activities and balance activities like yoga. So the take-home points I want you to remember are that geriatric assessment can help guide management. Oncologists are doing their best to tailor treatments, and consider vitamin D supplementation and exercise. Thank you so much.
Okay, thank you, Dr. Singh. That was an excellent talk for a challenging group of patients. And it's awesome that you're working on improving those outcomes for those patients. So next up, we're going to go back to multiple myeloma to close off the session. We have Dr. Kumar, who is a hematologist at the Mayo Clinic, world-known multiple myeloma physician who has conducted numerous clinical studies. He has specific research interests in patients with multiple myeloma, amyloidosis, and especially high-risk disease, which is a much-needed group for new and novel therapeutics. So he's going to talk about advances in multiple myeloma, which there are many of.
Thank you, Aaron, and thanks for having me in this panel. This is wonderful. Let me just bring up my slides. Okay. Hopefully the slides are visible at this time. Okay. All right, so what I'm going to try and focus on the next 20 minutes or so is the changes that have happened in the field of multiple myeloma, especially over the past decade or two. So I'll start off with, these are my disclosures, and I will start off with where we were a couple of decades ago. So this was actually a study that looked at data from a lot of different clinical trials that were done prior to 2000 and looked at the median survival of patients with multiple myeloma. And at that time, it was estimated that the average or the what we call the median survival is about 2.5 years in multiple myeloma. Now let's take a look at what has changed and why it has changed and where it is going in this area. So before that, I think one of the questions that often comes up is whether we can cure patients with multiple myeloma. And Dr. Rajiv already alluded to this earlier on. So one way of looking at whether diseases can be cured is to see if after a defined time period after diagnosis, whether the patients are continuing to die because of the disease. And on the top left is what we see in Hodgkin's lymphoma. You heard a little bit about in the previous talks. And you look, another one is the diffuse large B-cell lymphoma. And then there's follicular lymphoma, which is a different type of lymphoma, which is considered more indolent. And you can see that if you actually survive for 3 years after your diagnosis with Hodgkin's lymphoma, the chances of you actually dying from the disease is pretty low. Almost practically, your risk is same as a normal patient or person. So suggesting that the vast majority of the people 3 years from diagnosis are cured, or if they don't have evidence of disease at that point, they are unlikely to have the lymphoma come back. Unfortunately, that's not the case for multiple myeloma. Even after 3 years of diagnosis, even if you don't have active disease, the majority of the patients, the myeloma will continue to come back, as indicated by this black line, compared to what you would have expected is the red line. Now, the question is, how can we get there? And we certainly have made a lot of progress in the past 10 to 20 years that has put us on a path to getting to a cure in this disease. Now, one of the critical things with all cancers, not just myeloma, is that if you want to cure the cancer, we need to understand what makes the cancer tick. So understanding the disease biology is very, very important. We also want to ensure that patients are treated at the right stage of the disease progression. We need the right tools in order to do that, which in your case would be the medications, the transplant, and some of the newer therapies that Dr. Rajiv already alluded to. We need to treat them for the right duration in order to prevent the disease from coming back. And when the disease do come back in patients, we need to understand why that happens. And we need to do this all in the context of balancing the efficacy of the treatment, the side effects, and the impact the treatment side effects can have on the quality of life. So let's first talk about disease biology. Now, one of the things we have really come to understand over the past few years is that even though all the myeloma looks and behaves same in the clinic, you do the same test, all the cells look the same under the microscope, they all come, patients all present with similar problems like the high calcium, the renal or the kidney problems, the bone disease, anemia, all of which Dr. Rajiv referred to before. However, once you start looking under the hood, all these different myelomas are very different. And the major difference lies in the type of genetic abnormalities that these myeloma cells or the plasma cells have. And without going into details, there are 3 or 4 major categories of abnormalities. One of them is duplications of chromosomes. So you can have, instead of 2 chromosomes of a particular type, you can have 3 or 4 at times. There are other conditions called translocations, where a piece of chromosome from one chromosome goes and gets stuck to another one. Then there are what we call monosomies, which is loss of one of the chromosomes. Or you could lose a piece of a chromosome, what we call as deletions. Or else you could gain a piece, which is often referred to as amplification. But in addition to these big changes in the structure of the chromosomes, there can also be small changes in the genes themselves, and we are starting to learn more and more about those. Some of these changes are present at the time of diagnosis, and others appear as the patients go through different treatments. And what does that mean for the patients in terms of their long-term outlook? And this is a simple system that we created and very similar to others out there, where we can look at the number of what we call high-risk features. In this case, you have the different genetic abnormalities. We also have some blood markers like LDH and also other staging systems like the ISS that is also based on blood markers like protein, albumin, and beta-2 microglobulin. The bottom line is, by using all these different characteristics, we can group patients into 3, 4, or 5 groups, all with very different survival from the time of diagnosis. So obviously, not only do we need to get all these lines move up with our treatment so that everybody has benefit, but our job is even more tougher for those patients within the blue line, which are those patients with multiple high-risk abnormalities, because it's going to take us more than just a one-size-fits-all approach in order to improve their outcomes. Now, the reason myeloma is such a tough disease sometimes to treat is because it continuously changes its genetic makeup or characteristics. And some of it is because there are changes that happens within each cell on a serial fashion. But another important concept is that even at the time of diagnosis, you have a varied group of myeloma cells present, and they kind of go up and down depending upon whether the treatment being administered is effective against one or more of those. This is a great example of a patient where a diagnosis, you can, these different colors represent different clones or different subgroups of myeloma cells. And there is a sliver of blue here, which you can barely appreciate. But as the patient goes through different treatments over time, that blue sliver increases in size, and finally, all the myeloma cells pretty much comes from that particular clone or group of cells, which eventually leads to this patient's demise. So another important concept is tied to the earlier discussion about myeloma not being or being preceded by what we call precursor phases. So one of the good things about myeloma is that early stage, what we call the monoclonal gammopathy of undetermined significance, is often present for 15 to 20 years before patients get myeloma. So that gives us a window of opportunity to try and do something to alter what would typically happen to those patients. And in between, we also have what we call the smoldering multiple myeloma, which kind of bridges the gap between monoclonal gammopathy of undetermined significance and active myeloma that needs therapy. The importance of smoldering myeloma is represented or highlighted by this figure on the right-hand side, where you can see that in the red line, patients with smoldering myeloma, nearly half of them will get active myeloma in the first 5 years, and another 15% of them in the subsequent 10 years. So the bottom line is, once you have a diagnosis of smoldering myeloma, there is a 2/3 chance that patients are going to get active myeloma needing treatment within the next 10 years. This is very different than what we see in the MUGUS patients or the monoclonal gammopathy of undetermined significance, where only 1% progress every year. So at 10 years, only 10% of them have progressed. Now, if we can actually identify people at high risk of getting myeloma, should we not be doing something about it? Should we really be waiting for these patients to develop some of those, what Dr. Rajiv already pointed to as CRAB features? They can be very catastrophic. The first presentation could be bone destruction in the spine that compresses the spinal cord, or else it could be these myeloma proteins plugging up the kidneys and actually causing patients to need hemodialysis. So how the field has changed is that increasingly we would like to identify people who are at the highest risk to develop myeloma and do something at that point instead of waiting for the bad things to happen. It's also important to remember that the majority of the patients with myeloma gets diagnosed when one of those complications happen. Only a small proportion will get diagnosed with a MGUS or a smoldering myeloma. Now, if you do have a diagnosis of smoldering, we do have ways to predict, the progression of myeloma, the risk of progression to active myeloma. And based on the risk, we have done studies that have shown that an early treatment with just one drug, if need be, can actually alter the risk of progression and also make people live longer. And this has been replicated in other trials as well. And there are more recent trials which are looking at, instead of just using one drug, can we use a combination of drugs, like what we would do for patients with myeloma, and actually make these people not only live longer, but also reduce the risk of myeloma happening. So there are several trials going on. This is one trial which looked at 3 drug combinations and a transplant for patients with smoldering myeloma. And you can see that only 7% of the patients have progressed after 2.5 years, and almost all patients are alive after 2 years of diagnosis of high-risk smoldering myeloma. Now, the next important thing is, let's say the patient has come in with features or complications related to myeloma, and you make a diagnosis that this patient has active myeloma that needs treatment. The next important thing is to use the right set of tools and the right approaches in order to get the myeloma under control. So the way we use these tools depends to some extent on whether the patient is fit enough to go through a stem cell transplant. And that depends on age, depends on other illnesses that the patient might have, and of course, the preferences of the patient. Whether we treat them with a short duration of multi-drug combination, and then do stem cell transplant and then put them on maintenance with a low dose of one drug, or you do this whole thing without any transplant involved. The goal is to get patients to a point where we have very little of the myeloma cells left behind, and preferably none that we can detect with the current test that we have. So this is an area that has seen quite a bit of change over the past decade. About 10-15 years ago, this clinical trial was designed, which looked at a combination of 3 drugs: bortezomib, lenalidomide or Revlimid, and dexamethasone, and comparing it to just 2 drugs, which is the Revlimid and dexamethasone. And what the trial was able to show that 3 drugs was better than 2 drugs, not only in terms of keeping the myeloma away for a longer period of time, more importantly, making people live longer. Now that concept has caught on, and this is not really novel in the area of cancer treatment. We know cancer cells have a very high ability to transform, as we already talked about, and become resistant to treatment. So using multiple drugs with very different mechanisms can really make an impact in terms of trying to keep the cancer under check, as this clinical trial shows. Now, our experiments of clinical trials trying to improve treatments haven't stopped there. This is a phase 2 trial. I will a lot of details on this slide, but all I wanted to highlight is that this trial looked at that bortezomib, lenalidomide, or Revlimid and dexamethasone, the 3-drug combination, and examined if adding a 4th drug called daratumumab, which is a monoclonal antibody, does it improve outcome in patients who are going through a stem cell transplant. And what we saw, at least as of now with the early results, is that adding that 4th drug does lead to very deep responses, meaning we are able to eradicate a much higher proportion of the myeloma cells compared to 3 drugs. Now, obviously, there are more results that are awaited to see if people actually will live longer by using 4 drugs versus 3 drugs, like what we saw with the 3 versus 2 clinical trials. Now, once the patients get that initial 4 months or so of treatment, which is aimed at trying to kind of bring the myeloma under control, what we often refer to as injection therapy, then the next step is to try and see if we can get a deeper response by using treatments like autologous stem cell transplant in patients who are eligible to go through a transplant. Now, this was a trial that was done in France, and there was a similar trial done in the US as well, both with identical results. Both asked the question, instead of doing a stem cell transplant, can we just give another 2 or 3 cycles of the same treatment with the 3-drug combination? The trial showed that if you use the stem cell transplant as part of that initial package of treatment, your myeloma is likely to stay away for longer, roughly about anywhere from 12 to 24 months longer, depending on the particular study that you're looking at. Now, these 2 studies also showed that if somebody were to just collect the stem cells and not go to a stem cell transplant as part of their first treatment, patients still live the same duration because you can still use that transplant at the time myeloma comes back. Now, what if patients cannot go through a stem cell or after the stem cell transplant? There's also the question of maintenance treatments that are often used, which we'll come to in a second. Now, another big study that was done was looking at patients who were not eligible to go to a stem cell transplant, either because they were old, often we use the cutoff of 75 years, or because they have other reasons, other illnesses that may have precluded them from going to transplant. Here we ask the question of 3 drugs versus 2 drugs. So instead of using the Revlimid and dexamethasone, can we add daratumumab to Revlimid dexamethasone and improve the outcomes for patients? What the trial did show was that the use of the use of and the daratumumab as part of the treatment in these patients did lead to the myeloma staying away for much longer period of time, what we call the progression-free survival. Here you can see the blue line with daratumumab, and then added to lenalidomide dexamethasone, and the red line with the 2 drugs. Not only did it actually prevent the myeloma from coming back sooner, in fact, it kept the myeloma on an average away for about 5 years. It also improved the survival of patients with myeloma, meaning the patients treated with the 3 drugs actually lived longer than the ones treated with 2 drugs. Very similar to what we saw with the bortezomib or the Velcade and the Revlimid dexamethasone. Now, the next important thing is not only do we need to give very effective combinations of treatments at the time of diagnosis in order to get the myeloma down to that really low level, we also need to do something to keep the myeloma at that low level. So there has been this concept of maintenance treatment that is being applied to kind of keep the lid on the disease, so to speak. And one of the drugs that has shown the most benefit has been the drug called Revlimid, which is a pill that's often taken for 3 weeks out of 4 weeks or at a lower dose continuously. And there have been multiple trials that have shown that after an autologous stem cell transplant, if you keep patients continuously on the Revlimid maintenance, patients, the time the myeloma takes to come back can be doubled. And in fact, the patients can actually live for almost a year and a half to 2 years longer by using the maintenance rather than just not doing anything after transplant. Now, obviously, as has already been pointed out by Dr. Goodman, the treatment of multiple myeloma has evolved to a paradigm where we are treating patients continuously for long periods of time. We don't really know whether that is needed for everyone. So there is increasingly the concept, if we can get patients to what we call a minimal residual disease negative state, we might be able to stop the treatment in some patients. Unfortunately, we don't have the data to say that is the case for everyone. All we know is that if patients do get to a minimal residual disease negative state, their survival is much better compared to those patients who don't get to that MRD positive, MRD negative state. Now, one of the major changes that's happening in the field is for us to stop treating myeloma like with a one-size-fits-all approach. And as Dr. Goodman already pointed out, we really have to think about how can we treat patients with high-risk myeloma in a different fashion. So one of the major differences that we have, or the changes that has been implemented in the setting of high-risk myeloma, has been to use 2 drugs for maintenance instead of just using 1 drug. So this is a trial that was done in Italy, where they looked at a combination of carfilzomib or Kyprolis along with Revlimid for maintenance, and demonstrated that the 2 drugs is better than 1 drug in everyone, particularly in those patients with high-risk disease. The second important concept in the high-risk multiple myeloma has been this concept of sustained MRD negativity. So the question is, not only do we need to get them to that minimal residual disease negative state, which essentially reflects a stage where we cannot detect any myeloma cells with even the most sensitive technique that we have available. And also keeping those people at that stage or that level of disease for long periods of time. That kind of a approach, or I should say that sustenance of that MRD negativity, seems to really decrease the risk that is associated with having high-risk multiple myeloma. Now, whether every patient need to be there, or whether we can even give enough treatments to get every high-risk patients to that point is unclear. Now, unfortunately, as we already talked about, the vast majority of the patients with myeloma is going to have the myeloma come back. And we have to, at that point, do something different than what we did in the beginning. And thankfully, we have lots of different drugs for treating myeloma, as Dr. Rajiv already pointed out. We have the immunoimids, which is the pomalidomide and the Revlimid. We have what we call the proteasome inhibitors, which is the Velcade, the Kyprolis, and the Ninlaro. We have monoclonal antibodies like the daratumumab or Darzalex. Now, what we end up having to do is to create mixes and matches of these drugs to develop 3 drug combinations that we can use one after the other to control the myeloma. The way we do that is ensuring that patients at each time they need a new therapy, we come up with a combination that contains a drug that the patient has not seen before. That way we are able to get the maximum benefit out of each of these medications that we have. Now, obviously, you heard about the CAR T cells from Dr. Rajiv, and I won't go into that, but I think the immunotherapy has been one of the major advances that have happened in multiple myeloma in the recent past. And one of them is a bispecific T-cell engager. Now, all these different immune therapies rely on somehow making the T cells that are already in the patient, and these are the immune cells that can destroy the cancer cells, somehow make them see the myeloma cells better and kill them. Now, in the CAR T cells, you heard about how the T cells are modified outside the body and infused back in so that they can recognize the myeloma cells and kill them. Now, the bispecific T cell engagers or bispecific antibodies use a different approach where they use basically give these antibodies that can actually recognize the tumor cell and also recognize the T cell, in a way dragging them together so that they can actually now, the T cells can recognize the myeloma cell and kill them. I won't go into all the details, but it's important to note that we have several bispecific antibodies in clinical trial that are targeted towards very different proteins on the myeloma cells. One of them is already in the clinic called teclistamab or Tecveli, and that we are all starting to use in patients. Now, knowing that myeloma not only starts different, but also evolves differently, can be matched treatments to the patients based on some of those abnormalities. So one of the approaches has been to look at the genetic abnormalities. And we already heard about this drug called venetoclax in the previous talk with acute leukemia. But it also seems to benefit some of the patients with myeloma, particularly about 15 to 20% of patients who have a translocation called translocation 11-14. So this drug is currently in clinical trials. So in the future, we may be looking at a paradigm where we might actually do genetic testing on these myeloma cells in the patients, identifying what specific genetic abnormality they may have, and then giving them treatments that are targeted towards the genetic abnormality. And it may not be not just the genetic abnormality, there might be other characteristics that we might use as well. This is an example of a trial called My Drug that is currently ongoing that is looking at genetic abnormalities and whether we can give them a drug that is matched to that particular abnormality. So the big question, I guess, for us all is, are we actually getting closer to cure? For that purpose, I would actually point you towards the last two of these 4 figures. These are, again, patients with multiple myeloma we have seen at Mayo Clinic over a long period of time. And especially when you look at the last 2 lines, what we see is that if you have patients who are over 65 who are not high risk, those patients actually already seem to be living almost as long as what one would anticipate for somebody who does not have multiple myeloma. This is something that we often refer to as functional cure, that older patients with less aggressive disease being able to actually live a normal lifespan and die of something other than multiple myeloma. So we're making progress. We hope to have this paradigm applied to everybody with this disease. So I'll stop there and take any questions in the panel discussion. Thank you.
Okay, thank you for that talk. I need the host to let me use the video. It won't let me start my video. There we go. Let me get there. Now we can all see me. Great. So great talk. So we have a few minutes for the panel before we get to the patient questions. So please, right now, all patients or anyone listening, submit your questions, and we will do the best amongst us to answer as a team. Ask anything you want. So both were great talks. We'll go back to lymphoma, then I'll finish with Dr. Kumar. So Dr. Singh, you know, seeing older patients in clinic, especially with aggressive lymphomas, you know, it's hard for me because aggressive lymphomas are curable, okay? And in incurable diseases, it's easier for me to tone back, you know, the aggressiveness of my therapy. But in curable therapies, you know, as a clinician and clearly with informed consent, I'm more willing to risk, and I think patients are too. So, you know, kind of, you know, a busy clinic, you're seeing 20 patients in the community, even more. You know, I find sometimes the frailty assessments and all those things, like you don't have time to do them. And it ends up being you know, so how do you kind of approach that in the clinic? You know, let's just give an example of someone in their mid 70s who has relapsed DLBC, large cell lymphoma, an aggressive lymphoma that is coming to you for CAR T, and they're kind of borderline, you know? So how do you approach that?
That is such a great question, Dr. Goodman. I struggle with it. I do. And I tell patients honestly. So I conduct at the initial visit a geriatric assessment. With initial visits, I get an hour, and that's where I do that. And any sort of follow-up questions or other assessments, I can always send them additional questions through the portal. Afterwards, you know, I talk to them realistically about the side effects and what their goals of care are. So I always make sure it's patient-centered. And then from there, depending on if they really want that chance for cure, you know, and they're a little bit borderline, then I might start, for example, with like our mini chop and then go up to full dose R chop. Because my goal is always, as you suggested, is cure. And so I really want to make sure that the patients get all 6 cycles of chemotherapy in. And I would hate for them to get, you know, some sort of toxicity that puts them in the hospital and delays chemotherapy by a couple weeks, and then I don't end up getting the 6 cycles in because there were too many side effects. So, so I balance that, and I always look to my colleagues too. I talk to my colleagues. I ask them, you know, based on your experience, what are your thoughts? We do fortunately have a large population of older adults here in Phoenix, and so I'm able to, you know, get a really good assessment from my colleagues as well. Thank you.
And then I just have one question for Dr. Kumar. We'll be quick, and then we'll get to, I see these questions pouring in from the patients, which is great. So, you know, Dr. Kumar, so I do a lot of transplant, and there's 2 recent transplant studies, the determination IFM09, you know, so I used to, I'll be honest, just about everyone I was recommending transplant in myeloma, usually in first remission due to the prolonged PFS. I will say, based off some of those 2 studies, neither showing a survival advantage with some nuances involved with that, you know, my practice is starting to shift. So maybe the 72-year-old patient with myeloma who I used to do an auto transplant for sure, with Dara-Rev-Dex getting amazing long-term outcomes. It's well tolerated, especially a standard risk patient. So is your practice with transplant shifted at all, or how are you approaching that?
Yeah, it has shifted a little bit. I think you bring up a very good point about the overall survival. But, you know, another way to look at it is that, you know, we are not curing anyone. So I don't think we are at a point where we can discard any therapies that we have in our toolkit. So if you have a 72-year-old patient and you are in really good shape and you can go through a stem cell transplant, that is one person who might actually think about doing the transplant now versus even collecting the cells and storing, because it's quite likely, as you said, with the current injection therapy and transplant, they may be 78 before they might need the next treatment. And by that time, it would be totally not useful. But having said that, you know, there was a study from the ASH meeting last year, which showed that people who are getting like the reduced doses of melphalan for transplant, which we often do in people over 70, they don't seem to benefit from a transplant. So one shift that has happened is that if you're an older patient or a slightly frail patient whom I don't feel comfortable giving the full dose of chemotherapy, then I won't take them to a transplant anymore.
Yeah, no, I agree completely. Where we used to, I think, kind of push it and we go, oh, we'll lower it. But with that recent data, I agree that if you got that gut feeling, I think we're pretty good as clinicians knowing when to make that decision, that's what Art comes in, then I am deferring to. So so let's go. Oh God, there's so many questions. So I'm scrolling up. And anyone can, I'm just going to start reading these, and anyone who feels knowledgeable to answer these. So is there a preference as to which patients should receive? So Abecma and Carvykti. So these are the two CAR T cells for multiple myeloma.
Dr. Rajiv there, chime in.
Sorry, I was just getting my camera and all back in. Dr.
Oh
Goodman,
yeah, so I was saying, is there a preference? So with the two Abecma and Carvykti, so the two FDA approved CAR Ts that target BCMA, is there which one you reach for one over the other, or not a big deal for you?
Well, I can take a stab at it, and I would invite then Dr. Goodman and Dr. Kumar to, opine on it, because again, when I see in clinic, I think we do assess them for CAR T in general first, and then based on, there's always our institutions are limited by the slots that are provided by the companies, and they are not, even though they are trying to step up the manufacturing of these CAR T cells, these slots are by and large limited. We don't have an unlimited number, so we have to plan months ahead as to which slot goes for which patient. So that has been so far a very severe limiting factor. Also, I've also seen that, in patients in which we have a concern of, those who have a lot of extramedullary disease or those who have a higher risk for neurotoxicity, we tend to choose probably like we try to weigh if they really need to get Carvykti versus Abecma. So the presence of extramedullary disease, the risk for neurotoxicity, the availability of slots, these are considerations before getting someone to CAR T. But other than that, I think the right answer would be whichever is the fastest CAR T we can get them to, that would be what I would choose. And I invite others for nuances.
Dr. Kumar?
No, I completely agree. I think, right now we are not at a point where we can pick and choose. For a lot of the patients, we just use what we have. And unfortunately, there are no studies to compare the two. The only thing I would say in what we have implemented in the practice, again, not necessarily based on a direct comparison, is that some of the a little older, a little more frail patients, we often tend towards Abecma versus trying to use the Carvykti, and the younger patients may be a little bit more of the more towards Carvykti, purely based on some of the side effect profiles that we have seen with a slightly higher neurotoxicity with the Carvykti, but also at the same time, kind of a more durable response with Carvykti at this point in time.
Yeah, for me, it's whatever one we can get. And then really with patients with more rapid disease, I'm just going to teclistamab right now, now that it's available. And obviously we prioritize clinical trials in these patients. So the next question, in addition to what you've already said, is there a way to alleviate the cost of CAR T cell therapies? That's very difficult. Anyone want to go for that one?
I guess that is literally the $1 million question, right?
Yeah.
It's hopefully we can see some improvements as we see more of these products coming to the market, and particularly now with the bispecific antibodies being approved, I'm hoping that will also drive some of these. And eventually, at the end of the day, we need to also figure out who benefits the most from one versus the other. And even though we talk about the CAR T cost being high, bispecifics are not cheaper either. 1 year's bispecific therapy is almost as much as the CAR T.
Yeah, no, the CAR T, I mean, in theory, if we can get them better and they're potentially providing super long remissions, they will be cheaper than some of our other drugs that we are using in the field. So, and it's more regulation to try to fix those extreme costs.
I would also add that,
Yeah.
One of the research that I'm doing as a fellow is how to try to take CAR Ts to the outpatient setting.
Yes.
We actually have like an IIT that I wrote up, and in which we're trying to take patients to the outpatient setting using a combination of like wearable device monitoring and biomarker monitoring in a translation lab. We're trying to bring out a prediction, like can we predict which patients are at a higher risk for CRS? And then maybe if we at all reach that point, we can risk stratify those patients and keep those patients inpatient, and the others we can take outpatient. So if we at all reach that hefty goal we have set for ourselves, I think that is something that may help reduce the cost associated with hospitalization, infection risk, etc.
Those are great points. So let's move on. I want to make sure I'm not skipping one. So Dr. Jong, I saw the FDA approval to use, hopefully I'm pronouncing this one right, revumenib for acute leukemia patients with KMT2A rearrangement. So would that work for other rearrangements, or is it just for KMT2A?
Yeah, so I believe the revumenib is under FDA breakthrough designation, so it's not completely or fully approved yet. But the phase 1 study only involved patients who had that particular mutation, the KMT2A rearrangement. So we can't apply it to other mutations just yet. And there are many in the pipeline right now targeting different types of mutations and target proteins that are very exciting for patients with AML, and encourage everyone to consider enrolling into clinical trials for that purpose.
Yeah, and just it can be confusing. The KMT2A rearrangement, there's many different rearrangements that result in with that gene. So it's not just one, but it has to involve that specific gene that encodes that protein, which is what the drug's kind of working with. So that's what they're going after with that particular study. So the next question, Dr. Kumar, patients with 2 transplants and now a relapse, what is the next step forward?
So right now, I think with 2 relapses, we still have to use those combinations of different drugs. We talked about the proteasome inhibitors, the immunomodulatory drugs like the pomalidomide, Revlimid, and the monoclonal antibodies. So we have about a good portfolio of about 6 to 8 drugs that we can mix and match for those patients. Ideally, we would like to use something like a bispecific antibody or a CAR-T in those patients, but they are not quite approved at that stage. And that's what I think, Aaron, your point about making sure we put patients on clinical trial comes in. And hopefully the clinical trials can actually give access to some of these newer therapies, even for those patients who just have had 2 relapses.
Yeah, and the labels better than me, but for the new fancy drugs, was it 4 or 5 lines of therapy, which, sometimes patients can be refractory to a lot of those drugs without having had that many lines. So unfortunately, right, that's what the label is. And at least in my case, insurance is sticking to that label, and it's hard to write for those drugs unless they've met that. Yeah. So where are we now? So are there any ongoing trials for acute leukemia in adults?
Absolutely. There are many exciting trials. We have few at our institution as well, and I'm sure everyone else has their own set. I think one interesting one that we have is targeting a CD47, which is a immunotherapy sort of a marker called magrolimab, and we're hoping to get some good results in our TP53 mutated patients who are have a very aggressive type of leukemia.
Yeah, no, across ALL and AML, there are numerous studies using the CAR T-cell approaches, bispecific approaches, using pills, the target proteins, and combinations of all those things. And that CD47, the antibody that she's talking about, appears to be active, perhaps maybe in many different cancers, and it stimulates kind of your immune system to eat a bunch of the bad cancer cells. So let's see here. Dr. Singh, how do side effects differ in the elderly population? How can I best manage those symptoms in my family members?
Great question. So the aging system oftentimes has difficulty rebounding or recovering from some of the chemotherapy. So for example, the bone marrow often is very sensitive to chemotherapy. And so for patients who are 65 and older, the NCCN guidelines actually recommend giving Neulasta to stimulate the bone marrow to make white blood cells after chemotherapy. So I recommend that, making sure that your loved one gets that. And then I also recommend, letting your doctor know right away if you're having any symptoms, because sometimes they can give you like extra anti-nausea medication. So some of my patients who tell me that they're sensitive to nausea from medications, I'll actually give them extra antiemetics.
And then it looks like there's a follow-up question for you. Are there certain comorbidities in the geriatric setting that lead to a worse prognosis than others?
Yes. So as I showed, a lot of the studies focus on functional status. So your physical function, how active you are as a predictor, meaning it can lead to worse outcomes, worse survival, more aggressive disease coming back quickly. And so exercise, exercise, exercise. In fact, some of my patients exercise so much that they exercise more than I do, and I need to follow suit. So you really want to make sure you exercise now and keep it up as much as possible while you're going through chemotherapy.
So this is for Dr. Kumar. What would be the first step in treatment for a patient age 63 diagnosed with multiple myeloma who also has type 2 diabetes?
It's a great point. One of the drugs that we love to hate is dexamethasone, as would everybody. Our patients don't like it either. And I think that is one of the key differentiating things when you talk about diabetes in a patient with newly diagnosed myeloma. So we had to really watch the treatments are going to be the same to start with, but we can certainly start with a lower dose of dexamethasone in some of those patients, especially in the older ones. Instead of using the 40 milligrams, you can try starting with 20 milligrams, and of course, watching their sugars very closely. But I think one of the things we have learned in the past few years is we probably don't need to use as much of the dexamethasone as we used to use. In fact, some of the recent trials have shown that maybe we just need it only for the first couple of months and can rapidly start bringing it down. We certainly have very strong data to say that we don't need to use anything more than the 40 milligrams a week. We certainly don't need to use it for more than the first 6 to 9 months. But hopefully the new crop of trials will tell us that we may only need to use it in the first 1 or 2 months, primarily to control some of the reactions to medications and so forth.
Okay. What are the pros and cons of CAR T-cell therapy versus bispecific antibodies? I think, I
Rajiv,
can, yeah,
okay,
you chimed in a little bit on this earlier, but we can, again, it's, CAR T cells, I think the main sell point of CAR T cells, and again, it depends on what disease we're talking about, but, they're a one-time therapy that's intensive and labor intensive and requires quite a bit of workup, but it's one and done, and hopefully a long durable remission, which is great. And I think all patients value being off treatment. So I think that's a big selling point of CAR T cells. The disadvantages of the CAR T cells, expense, although all these things are expensive, and it takes time to engineer this. Patients referred to my clinic, I have to say, I think you need a CAR T cell. So that's the first step. So they have to be from the community. They got to get an appointment and see me. We see them fast, but there's still some delay. I have to say, I think you need a CAR T cell. They have to undergo an evaluation, almost similar to like a stem cell transplant, where we know they have social support, logistics. We have to then collect their cells. They have to engineer the cells. That whole thing takes, 6 to 8 weeks, sometimes even longer, depending on slot availability. So that's a major disadvantage. And for some of our patients, they cannot wait that amount of time. Bispecifics, you can give, it's right off the shelf. They don't need to cook it. It's already made. And it can be given once you get approval immediately. I think a big disadvantage currently is their continuous therapies. Although in lymphoma, there are now some studies discontinuing the bispecific antibodies. They just presented at ASH where they discontinued one of the CD20 bispecifics, and there were very durable, complete remissions, perhaps cures. In myeloma, I would ask the myeloma experts in the room, are they looking at discontinuation studies in the bispecifics?
Yeah, for sure. I think some of the studies are looking at either 12 to 24 months of bispecific treatments. And I think it's a very important point, because one of the things that we do see with the bispecifics is a high rate of infection, particularly severe infections. And whether this is related to the bispecific, or of course, these are patients who have been through a lot of different treatments, 5 or 7 treatments sometimes. So it could also be that the patients have a weakened immune system, but nevertheless, I think what we see certainly is something we need to watch closely. And I think one of the ways to try and avoid that might be to give a defined duration of treatment.
And I don't know if I'm missing it. So I have here, how can we, oh no, I see a follow-up question to kind of CAR Ts. Is it better to, this is a good question, tough question. Is it better to move cellular therapies earlier up? So currently in myeloma, it's off clinical study. It's reserved for 4th or 5th line therapy for CAR T is the approval. While in lymphoma, it's approved on various indications, either first or second, or in some cases, 3rd relapse. So would it be better, why not just do this in all newly diagnosed patients? So anyone in the group, are we studying this now? And what are some pros and cons of that approach? Dr. Rajiv?
Yeah. So I think there is definitely studying like CAR Ts in the more earlier lines of therapy, because we do have a couple of trials open at my institution. And, there are various arms of that trial, and I think it's encouraging. And I think the dogma of reserving good therapies for later in the line has been challenged, because we want to give patients the best treatment as early as possible. So that's why I think these trials have been designed, and there are certainly many trials ongoing in which CAR Ts are now moved to the first line setting, second line setting, earlier line settings. We should have a readout of these trials hopefully in the next few years, and hopefully myeloma can replicate the ZUMA-7 success that lymphoma had, which actually was CAR Ts the earlier line for aggressive lymphoma. So very hopeful for that.
Yeah, these studies are occurring, and we're gonna continue to try to move up these therapies or combinations of these therapies. Again, it's going to be very important that we show in a well-designed, we have very good outcomes in myeloma right now. We show, and I think it's probably, when we look at moving these therapies up, especially with significant risks, we like to study higher risk patients first who aren't doing optimal with our current approach. So like in lymphoma, we looked at patients who relapsed right away after chemotherapy. And those patients don't do that well with our current approach. And so we moved up CAR T and we've had success. So I think in myeloma with the higher risk, moving those therapies up, but we're still going to have to show, in a controlled fashion that by doing that, it's safer and better, and our patients are doing better with those approaches. So those studies will take time to figure that out. But I'm pretty optimistic of a future that, we're going to be using immunotherapeutics in lymphoma and myeloma with less of, I do transplant. I don't ever need to do another auto transplant again. If we can figure out a way to get rid of it, I'll celebrate that day. And if you ask me now, I truly believe in 10 years, that we will, if you say, what do you predict? I do think that we're going to get there. Just what I've seen since the last 5 years in my practice. I mean, patients, I have this discussion all the time with myeloma or lymphoma. They go, well, what are you going to do when it comes back? And I tell you, I have no idea, because in 5 or 6 years, it's going to be completely different and better. And it's a good problem to have. Okay, let's see. Do we have any other points? So how can we find clinical trials? Do we talk to our doctor, or is there a better way?
I think the first step would be to discuss with your doctor, but there are other ways to see what clinical trials are out there. And a good, resource would be the National Cancer Institute website, where we have all of the clinical trials registered, so that you can easily sort of look up by disease or by medications, and see what participating institutions there are. So that would be probably the best way.
Yeah, and always discuss with your doctor, but in many cases, clinical trials that are well designed are the best option, sometimes even with newly diagnosed disease. So even in the community, they have trials, they can always refer you out for opinions. And then a lot of the societies, like the Myeloma Society, the Leukemia Lymphoma Foundation, have links to different clinical trials and things. But I do think it's best to just ask your doctor, and they'll give you a good starting point.
I'd also like to add, patient advocates are great. So if you can get onto like some patient advisory board or an advocate group, you could learn a lot from your colleagues and peers as well.
Okay, and then we have here, does smoking increase the risk of acute myeloid leukemia?
I think there are some suggestions, speculations that smoking is related or can increase the risk of developing acute myeloid leukemia. Regardless, smoking is bad for many other reasons too. So I encourage all of my patients to quit if possible.
Yeah, it's never too late to quit. Well, in most cases, and anytime you're getting active therapies and you're smoking still, it could just make things harder. So yeah, there is I believe an association with AML. My grandfather had multiple myeloma. My grandfather had multiple myeloma. Do I have an increased risk of that? And what about my own children?
I think that's a loaded question. There are many factors that, lead to the evolution of myeloma. There have been associations and studies of genome-wide association studies that looked into whether there are like inherited genes that can be linked to myeloma. These studies, large studies, are ongoing. What we know for a fact is that there are some clusterings of genes that do predispose to having a higher risk, and that risk is estimated to be 2 to 3 times than the general population. But then, confirmatory studies are pending. There's also like a racial disparity seen. If your race happens to be of African American origin, you are at a higher risk. That being said, I think it's a discussion to have with your your grandfather's oncologist, and seek genetic counseling if may.
Yeah, I think, as you said, there's clearly a 2 to 3-fold higher risk in the first degree relatives. So clearly, and that seems to be partly genetic and partly environmental driven. But clearly, both the the racial makeup also increases the risk. And of course, if you have more than one family member, then your risk also goes up. Again, suggesting that there's probably some kind of a genetic factor that is driving it. But we still wouldn't do anything. We definitely not recommend screening in everybody, just because the fact that, as I said in the beginning, this is a very uncommon condition compared to a lot of other cancers. And even with the 2 to 3-fold higher risk, you're still looking at very low risk in the absolute terms. So, widespread screening is not something we would recommend at this time.
Okay, and I think this will be your last. I don't think there's any other questions. So I want to thank, I greatly appreciate the time that the panel came on their Saturday to spend with us. It was a pleasure to listen to each one of you talking, and I greatly appreciate you guys participating in this. And I learned a lot. And I want to thank everyone in the audience also for coming and spending time with all of us. And again, we're all reachable. My email, they can provide my email, the organizers, and we're free to answer questions and help with your care at any time. Thank you so much.
Thank you, everyone.
Thank you.
Take care, everyone.
Thank you.
Bye.